I would like to thank Prof. Agarwal and Prof. Varma for these very kind words. I would like to share with you some data regarding the role of minimal residual disease assessment in multiple myeloma. Why, in fact, to assess minimal residual disease? We know that the main rationale, in fact, is the correlation between the response to treatment and the outcome. We know perfectly that the best response that the patient is going to achieve, the longer duration of response it will have. This is true for progression-free survival, but also for overall survival, as you can see on this slide from the Spanish group for patients treated with autologous stem cell transplantation. When patients were reaching CR after stem cell transplantation, and this paper was published quite a long time ago, in fact, the overall survival of patients was really improved as compared with partial response only, for example, or obviously for progressive disease. We know now as well that with new combinations, such as VCD, VRD, that we are all of us using in our routine practice, almost 100% of the patients are going to respond. And many of them, in fact, half of them, 60, 70% of the patients are going now to reach CR. But almost all of them, the great majority of them, are going to relapse, suggesting that despite this CR achievement, we have an undetectable disease that may be present and will provoke the relapse. So back to this very old paper, in fact. For the first time, it was necessary to try to have a consensus on the response, and that was mostly because of the introduction of high-dose therapy and autologous stem cell transplantation. And in 1998, in fact, more than 20 years ago, we have introduced the Blades criteria, proposed by Joan Blades from Barcelona, because some patients were able to reach complete response. Later, in 2006, the International Myeloma Working Group reported an update version of these response criteria with the introduction of stringent CR. It was the first time what we spoke about stringent CR, that it was CR plus the normalization of the free light chain ratio and the absence of clonal cells in the bone marrow by either immunohistochemistry or immunofluorescence. 5 years later, Vincent Rajkumar from Mayo Clinic introduced the idea of immunophenotypic CR or molecular CR, and we were able to upgrade the response. It was for immunophenotypic CR, stringent CR, plus the absence of clonal cells with 4-color cytometry. So for the first time, we have introduced 10 years ago the idea of assessing the tumor clone within the bone marrow with 4-color flow cytometry. And we know that now we are going to use next generation flow. We also can assess next generation sequencing and PET-CT. And this paper from Dr. Sonneveld in 2016 is nicely showing the evolution of the response criteria, EBMT, Blades, International Myeloma Working Group, version 1, version 2, and now we can assess the minimal residual disease within the bone marrow, but also outside the bone marrow with imaging techniques such as PET-CT. And we are using new agents, definitely. You know that we have carfilzomib, that is the second-in-class proteasome inhibitor, pomalidomide, and monoclonal antibody. And the depth of response is now increasing, and we need to have new tools to assess minimal residual disease. So we are going to speak now about flow, about NGS, about PET-CT to assess MRD. And you know that in 2016, we have, with the International Myeloma Working Group, tried to define a new consensus. And this is a current consensus that we have. This is the last one. In fact, we don't have an update paper discussing the response. And into this paper proposed by Shaji Kumar as a first author, Mayo Clinic, Rochester, Minnesota, we define flow MRD negativity with the assessment of a sensitivity threshold of 10 to the minus 5 within the bone marrow. We also proposed the NGS assessment, and patients MRD negative are reaching as well the threshold of 10 to the minus 5. And into this paper, in fact, we also discuss imaging plus MRD negative. And imaging negativity is the assessment of MRD negativity within the bone marrow, defined by NGF N or NGS, plus the disappearance of the uptake of the previous PET-CT. So we have now these new definitions that are available, but these flow MRD negativity, sequencing MRD negativity, or imaging MRD negativity are all of them requiring a CR. So only patients in CR can be assessed according to this paper with flow with the NGS or PET-CT. And we know that definitely MRD is relevant. In an important paper, one of the first meta-analysis of MRD was proposed by Nikhil Munshi from Boston. And Nikhil looked and published in 2017, looked at all papers focusing on MRD negativity and comparing, assessing the outcome of patients when they were reaching MRD negativity, not only for progression-free survival, not only PFS, but also for overall survival. And you see here the number of studies, 13 studies were included into this paper for PFS. 9 studies at that time were survival, and in all of them, prospective analysis of CR, MRD negativity, and the outcome into a clinical study. And in fact, all of them in CR, you see the effect of MRD status on PFS. And definitely in yellow, you see MRD negative patients versus MRD positive in blue. And the p-value is really in favor of MRD negativity for the final outcome. But this is also true, and that's obviously more important for overall survival. All of these patients, again, were in CR. Subsequently, MRD within the bone marrow was evaluated. But into this paper from 2017, the clinical trials were performed in 2013, 2014, 2015. And then the MRD assessment was mostly based on flow cytometry, and for the majority of them, 4 to 8 color flow, and the threshold was not 10 to the minus 4. And you see here the impact on overall survival with a clear benefit even at 10 to the minus 4 for MRD negativity. So MRD is definitely predictive based on this meta-analysis, or both a longer PFS, a longer overall survival, but those results, as I did mention, were mostly achieved with flow cytometry, with quite a low sensitivity into this paper. So the next question is, would a higher sensitivity have a better predictivity of the outcome? And you know that we have new tools to assess MRD in myeloma. We have next generation flow with 2 tubes, 8-color flow, what we are calling Euroflow technique. That is now very well standardized. We also have next generation sequencing that is also standardized and is approved by FDA. And outside the bone marrow, we can also use PET-CT to assess MRD negativity. And you see that there are some differences when comparing flow versus NGS, the 2 techniques that are looking at MRD within the bone marrow. The time for performing this analysis is totally different, in fact. The cost is also different. The sensitivity is probably in favor of NGS. It is more easy to reach 10 to the minus 6 with NGS, and we don't need fresh samples. This is the opposite of flow, where we need fresh samples. We are not exactly speaking about the same techniques. Some of us will think that flow is more easy to use because we are using flow for many other diseases, such as acute leukemia, CLL, but flow for multiple myeloma, to my opinion, is a little bit different, more complicated as compared with flow for CLL, for example. So do we need to reach 10 to the minus 6? Or is 10 to the minus 5 the optimal threshold as proposed by the International Myeloma Working Group consensus paper? Do we need flow or NGS is better? So many question marks here, and I will show you some data now. This is the French study for young patients eligible for autologous stem cell transplantation. The paper was published in 2017 in the New England, the 2009 study. We have randomized 700 patients, young patients, to receive either VRD without stem cell transplantation or VRD plus stem cell transplantation. And in the 2 arms of the study, patients subsequently received lenalidomide maintenance during 1 year. And we did assess MRD systematically before and after maintenance, and we looked primarily at 7-color flow with a threshold of 10 to the minus 4, in fact, and that's not the Euroflow technique, 10 to the minus 5 or 10 to the minus 6. At that time, Euroflow was not available yet. But for some patients, a subgroup of patients, we were also able to look at NGS. You know the results of this study showing that in blue, stem cell transplantation is associated with the best progression-free survival, 50 months, versus 36 months with VRD alone. But interestingly, overall survival is not different when comparing VRD versus autologous stem cell transplantation. And we are going to update in a few days at ASH with a very, very long follow-up this analysis. And you will see that there is no overall survival difference with the follow-up that is now almost 10 years. So definitely no OS difference, suggesting that with VRD, you can rescue with a salvage stem cell transplantation at the time of the relapse, you can rescue patients progressing on VRD alone. But when looking at responses, Interestingly, and patients were assessed by flow cytometry, 7 color, 10 to the minus 4. You see that the higher rate of MRD negativity was achieved with stem cell transplantation, and before maintenance, 80% of the patients in the transplant group were able to achieve MRD negativity. And interestingly, when we looked at prognostic factors for progression-free survival, the most important one in this mutative Cox regression analysis was the achievement of MRD negativity. And when you are looking in the all patient population, the intent to treat analysis of 700 patients, patients reaching MRD negativity in blue have definitely a better outcome, and that's true for both arms of the study. And interestingly as well, if you are reaching MRD negativity, overall survival is significantly improved. So definitely the goal of a new strategy for young patients in the setting of stem cell transplantation is to reach MRD negativity that is, into this study, associated with an overall survival benefit. I told you that we looked at, in a subgroup of patients, only at NGS, 10 to the minus 6. And definitely you see that before maintenance, those patients reaching MRD negativity with a very stringent threshold, 10 to the minus 6, the outcome for PFS is totally different in favor of MRD negative patients. And interestingly, this picture is showing all patients reaching MRD negativity by flow, 10 to the minus 4. And into this patient population, all of them negative at 10 to the minus 4, we looked at patients MRD negative at 10 to the minus 6, and you see that there is only a subgroup of patients, half of the patients were negative 10 to the minus 4, all of them by flow, but only half of the patients were also negative by NGS at 10 to the minus 6. And definitely the outcome is different. You can be negative at 10 to the minus 4, but positive at 10 to the minus 6 with NGS. And you see that the outcome is different. In fact, it really means that the threshold 10 to the minus 4 is not the optimal one. And when you are reaching 10 to the minus 6, definitely your outcome will be better. And this is the whole picture, in fact, with NGS. You see 10 to the minus 6, that's the upper curve in blue, 10 to the minus 5, 10 to the minus 4 in green, and those patients that are not reaching 10 to the minus 4, you see the outcome is much, the progression-free survival is really shorter. So definitely the best response you achieve, the better outcome for the patient. And this is a clear demonstration into a clinical study with homogeneous treatment for our patients. And this is overall survival. Not only PFS matters, but OS. And you see here the cutoff value of 10 to the minus 6, MRD negative patients in blue and MRD positive patients in red. And interestingly, we looked at the treatment arm, VRD alone or VRD plus stem cell transplantation. And as soon as you are reaching MRD negativity, the outcome is identical, suggesting that you can reach MRD negativity with VRD alone at 10 to the minus 6, and definitely your outcome will be identical to that of patients treated with stem cell transplantation. So the goal is not to select potentially the stem cell transplantation for all patients, but when you are reaching MRD negativity, maybe you can get rid of stem cell transplantation. But this is a question mark, and it has to be demonstrated, to my opinion, into a clinical study, a prospective one. What about cytogenetics? We thought that maybe with MRD negativity and high-risk disease, the outcome will be identical. This is not true in this study with VRD plus or minus stem cell transplantation. And you see definitely that MRD negative patients in blue with standard risk versus negative MRD negative patients with high risk in red. There is a difference in the outcome of patients. But the numbers are very small and we need a larger patient population before claiming that with high risk disease, even if you're achieving MRD negativity, your outcome will be inferior. So this is the study design of the Spanish group. They did propose VRD times 6 as induction, followed by stem cell transplantation prepared either with MEL200 or BuMEL. Patients subsequently received 2 cycles of consolidation before maintenance. And our colleagues from Spain, Jesus San Miguel, Laura Rossignol, Joan Blade, Mariví Mateos, looked at MRD after induction, after stem cell transplantation, and after consolidation. And Bruno Paiva did the analysis. And you see that over time, the responses are deepening after induction, after stem cell transplantation, after consolidation. The CR rate, 38%, 49%, 58% after consolidation. And the rate of MRD negativity was also improved. They looked at all patients with next generation flow cytometry, what we are calling Euroflow, and you see that the patient MRD negative patient population is increasing 35%, for 54%, 58% after consolidation. So definitely an important information. And when you are looking at PFS, according to flow cytometry, the most recent one, with the threshold of 10 to the minus 5 or 10 to the minus 6, in fact, patients MRD negative have a better outcome. So those data are confirming the French results with a better threshold, 10 to the minus 5 or 10 to the minus 6, in the setting of VRD, stem cell transplantation, and consolidation. They looked at the depth of response, and definitely they are also showing that when patients are reaching MRD negativity or 10 to the minus 5, 10 to the minus 6, 10 to the minus 5, etc., we are able to segregate patients according to the depth of response. So this is a very important confirmation of the French study. And they don't have exactly the same results in terms of cytogenetics and PFS. You see here that according to the Spanish results, those patients reaching MRD negativity with standard risk or high risk, in fact, they have exactly the same outcome. That's the two upper curve, standard risk and high risk, MRD negative patients, the outcome is identical. So there is here a question mark that, to my opinion, is still remaining to be discussed. Well, do patients with high risk cytogenetics reaching MRD negativity have the same outcome as compared with patients with standard risk? That we don't know exactly. According to the French group, the outcome is not identical. According to the Spanish group, the outcome is identical. This paper is showing, in fact, the comparison of next generation flow and NGS for patients treated with stem cell transplantation. And that's a sub-analysis of the previous paper that I showed you, that was very recently published in Blood Cancer Journal a few weeks ago. So they looked at the two techniques, NGS, 10 to the minus 5 or 10 to the minus 6, and flow, Euroflow, 2 tubes, 8 colors, 10 to the minus 5 or 6. And you see that the results are strictly superposable. And our colleagues from Spain are claiming that we can use either NGS or NGS, and we will, if we are focusing on 10 to the minus 5 or better, we have exactly the same outcome. So the two techniques are, in their hands, identical in terms of results. So the current consensus that we did published 5 years ago is already old-fashioned, yes or no. We discussed about the threshold of 10 to the minus 5 for both flow and for NGS, as I mentioned previously. And we know that potentially 10 to the minus 6 is more important. So are we ready to change the proposal for 10 to the minus 6 instead of 10 to the minus 5? I'm not sure, but this has to be discussed with Shaji Kumar and all the colleagues from the Myeloma, International Myeloma Working Group. I mentioned previously that we can also use PET-CT as an important tool to assess MRD outside the bone marrow. And Dr. Barloghi, in fact, when he was working in Little Rock, Arizona, quite a long time ago, was the first with his team to claim that PET-CT was very important to predict the outcome of the patients. And on a large number of patients in this work published, as you can see, more than 10 years ago, Bart was the first one to show that when patients, after induction and before stem cell transplantation, at the time of the first stem cell transplantation, when patients had a PET negative assessment in blue, overall survival was improved as compared with patients with a PET that was remaining positive at the time of the first transplant. Into this study, all patients were treated with a total therapy with a tandem stem cell transplantation. But Bart was the first to identify PET as an important tool to predict overall survival for patients treated very aggressively. The data from Bart were, as you know, confirmed by the Italian group from Bologna. And you see here the outcome of patients for both progression-free survival and overall survival when PET-CT was negative after stem cell transplantation. So the overall survival is improved, PFS is improved, suggesting that PET may predict the outcome not only after induction, but also after stem cell transplantation. And this is the picture of progression-free survival for patients achieving CR after stem cell transplantation. So patients, all of them were in CR, but some had a PET that was remaining positive, and some others in CR had a PET negative assessment. And you see definitely that it was important to be in CR, but in addition, on top of CR, PET negative as well. And the outcome was improved for those patients, CR and PET negative. So we did a similar study within the French IFM 2009 trial, comparing, as I mentioned previously, VRD versus VRD plus stem cell transplantation. We did a prospective assessment of PET-CT and MRD at the time of diagnosis, but also before maintenance. And we were able to demonstrate that progression-free survival was improved for those patients in blue, PET negative before maintenance therapy. We also showed that overall survival was improved significantly when patients had a normal PET-CT before maintenance. So the normalization of PET is an important prognostic factor in the setting of VRD plus or minus stem cell transplantation before maintenance. So an important information confirming the data from Bart Barloghi, confirming the data from the Italian group. But we were able to compare on the same patient population, PET and flow cytometry. And interestingly, we demonstrated the number of patients is not that high, but we demonstrated that there were some discrepancies. Some patients were PET negative, but MRD positive, and on the opposite, some patients were PET negative and MRD positive. So the two techniques, imaging with PET and MRD within the bone marrow by flow, are providing different informations. And you see here, this picture is very important to my opinion, and we published this paper 3 years ago in the GCO. You see here in blue, those patients reaching MRD negativity before maintenance, not only within the bone marrow with flow, but also outside the bone marrow with PET, what we are calling double negative, versus in yellow, patients with either PET positivity by MRD positivity by PET or MRD positivity by flow cytometry. So definitely it is good to be MRD negative within and outside the bone marrow, and definitely your outcome will be improved. So really, I think that the consensus paper from the International Myeloma Working Group is really old-fashioned, in fact. Not only the threshold of 10 to the minus 5 can be discussed, but looking at the definition, imaging a negativity was requiring MRD negativity within the bone marrow plus PET negativity. And definitely, we are showing here that there are some differences. Some patients are PET negative, but MRD positive, and vice versa. So what are the results of MRD in the context of novel combinations used as frontline treatment? And you know that we tested with the French group the comparison of VTD versus VTD plus daratumumab, both before and after autologous stem cell transplantation, into the Cassiope study. So this is the study design: young patients eligible for stem cell transplantation, VTD versus VTD DARA, both before and after stem cell transplantation. And we showed that the progression-free survival was improved for those patients receiving the quadruplet combination with a hazard ratio of 0.47. So a huge improvement, in fact, with the addition of daratumumab on top of VTD. And we looked systematically before maintenance at MRD by flow cytometry, Euroflow, the most recent technique, 10 to the minus 5, on all the whole patient population, more than 1,000 patients. And we showed that with DARA VTD, the MRD negativity rate before maintenance was 64% versus 43% only with VTD. So definitely DARA VTD is improving the MRD negativity rate. And when you are looking at the outcome of the patients according to MRD negativity, and we looked at flow for all patients, but also NGS 10 to the minus 5 on a subgroup of patients. But the subgroup is very important. That's more than 800 patients that were analyzed for NGS as well. You see definitely that those patients reaching MRD negativity have a better outcome. And interestingly, we have, when comparing VTD MRD negative patients and DARA VTD MRD negative patients, the outcome is not identical. And with DARA VTD, the outcome is much better, indicating that potentially we are reaching 10 to the minus 6 more often with a quadruplet as compared with VTD alone. We also looked at MRD negativity, and those data are not yet published. We looked at MRD negativity post-induction and before stem cell transplantation. So after 4 cycles of either VTD or DARA-VTD. And with the quadruplet combination, the MRD negativity rate is 34% versus 23% with the VTD alone. So a higher rate of MRD negativity with the quadruplet after induction. And we looked at multivariate analysis of progression-free survival, including MRD negativity after induction. And definitely the 2 factors that are predicting progression-free survival are the treatment group, DARA-VTD versus VTD, but importantly, very importantly to my opinion, post-induction MRD negativity. So when you are reaching after induction and before stem cell transplantation in the setting of a quadruplet induction, reaching MRD negativity, definitely the outcome of patients are improved. So it indicates that in the context of the most recent combinations, you may predict the outcome of patients immediately looking at MRD very early before stem cell transplantation. And you see here the outcome of patients that were MRD negative after induction when receiving VTD daratumumab followed by stem cell transplantation. That's the best outcome of our patients. The Griffin study in the US looked at VRD instead of VTD plus or minus daratumumab. So the study design is very similar to Cassiope, VRD or VRD-DARA, both before and after stem cell transplantation. The paper was published recently in Blood by Dr. Voris. That's a phase 2 study, 200 patients. And you see that over time, very similarly to Cassiope, the responses are deepening after induction, after stem cell transplantation, after consolidation in the 2 arms of the study, and the best responses are achieved with VRD daratumumab. And when looking at MRD negativity rates after consolidation and before maintenance, you see definitely that we have a higher MRD negativity rate with the quadruplet combination in patients reaching CR, 30% of MRD negativity versus 10%, and in patients achieving CR or better, 60% of MRD negativity with VRD-DARA versus 25% with VRD alone. And when looking at subgroups of patients on the right-hand side, MRD negativity results before maintenance and after consolidation, all subgroups of patients are reaching MRD negativity with VRD-DARA versus VRD, significant improvement of MRD negativity rate with the quadruplet combination. Is it true in the real life, in fact? Because we spoke here about Cassiope, VTD-DARA, we spoke about VRD-DARA, but in 2 clinical trials for selected patient population. This is also true in the real life, and this paper is coming from the group of California, recently published in Blood Advances. You see that in the real life as well, newly diagnosed patients receiving stem cell transplantation have both a better progression-free survival, but also a better overall survival when they are reaching MRD negativity 10 to the minus 5 or 10 to the minus 6. You see the impact of MRD negativity in the real life. So do we need to use MRD assessment in the routine practice outside clinical trials? That will be probably one of the questions that we are going to discuss later, but I guess that we are almost ready for using MRD negativity in routine. What about elderly patients treated without stem cell transplantation? And one of the best combination is DRD, Lendex daratumumab, in this Maya study published in the New England 1 year ago. You see the best outcome with Lendex daratumumab frontline for elderly. This is the study design, Lendex versus DRD until progression, and the progression-free survival, as I mentioned previously, highly improved. And this is the update analysis with a longer follow-up presented at ASH. And definitely the responses are improved with DRD, but importantly, the MRD negativity rates are also improved with the triplet combination versus Lendex alone. At the time of this report at ASH, you see that almost 25% of the patients were able to reach MRD negativity by NGS 10 to the minus 5 with the triplet combination. And interestingly, progression-free survival is highly improved for patients reaching MRD negativity with DRD. This is also true for Lendex and achievement of MRD negativity. But as you can see at the bottom of the slide, the patients reaching MRD negativity, the number of patients reaching MRD negativity is much higher with the triplet as compared with Lendex alone. So maybe we could also mention that MRD negativity is important, an important goal for the treatment of elderly patients with DRD or other regimens. And this is also true into the Alcyone study. Alcyone looked at, as you know, VMP versus VMP plus daratumumab. The paper was published in the New England 3 years ago. This is the study design, VMP, fixed duration, 9 cycles, versus VMP DARA, 9 cycles, followed by DARA maintenance. The update analysis of progression-free survival published, reported by Tanos Dimopoulos at ASH. You see that the DARA VMP is associated with the best progression-free survival, but MRD negativity was also assessed at 10 to the minus 5 for patients reaching VGPR or better. And same story, when you're looking at the outcome of patients for PFS with DARA VMP MRD negative or VMP alone and MRD negative, the outcome is really improved as compared with MRD positive patients. And the same for the number of patients reaching MRD negativity, that is much higher with the quadruplet combination as compared with VMP alone. So definitely MRD negativity matters not only for frontline treatment in young patients, but also for elderly patients. And MRD is important in the relapse setting as well. These are the data from the Castor and Pollux study. Pollux looked at Lendex versus Lendex daratumumab. Castor compared VD in the relapse setting versus VD plus daratumumab. And when you are looking at MRD negativity rates at different threshold, 10 to the minus 4, 10 to the minus 5, 10 to the minus 6, there is always a benefit with the addition of daratumumab. And for example, at the threshold of 10 to the minus 5, that is the official one, we have 25% of patients reaching MRD negativity with at 10 to the minus 5 with DRD, and we have 10% of the patients reaching MRD negativity 10 to the minus 5 with VD-DARA. And this translates into a better progression-free survival. So exactly the same picture, patients MRD negative with either Lemdex or Lemdex Dara, MRD negative with VD or VD daratumumab, better outcome for PFS, and the number of patients reaching MRD negativity is higher with the addition of Dara on top of Lemdex or VD. I will. Those slides were showing the same results. And is it true outside clinical trials in the real life? And this is also the experience of the group in California from Thomas Martin and his colleagues. We have here the outcome of patients treated in the real life, either reaching MRD negativity either at 10 to the minus 5 or 10 to the minus 6. And you see definitely that in terms of PFS, we have a better outcome in the relapse setting in the routine life with MRD negativity versus MRD positivity. Let's speak now about the concept of sustained MRD negativity. That, to my opinion, is the most important one. The concept was really clearly stated into the paper from the International Myeloma Working Group. You see what was the proposal from Shaji Kumar 4 years ago. Sustained MRD negativity is defined by MRD negativity in the bone marrow with NGS or NGF, and by imaging. So both MRD within the bone marrow plus PET confirmed minimum 1 year apart. So a serial assessment of MRD negativity both within and outside the bone marrow and 1 year apart. And then those patients MRD with a sustained MRD negativity potentially may enjoy better outcome. So this proposal was based on very, very few data at the time of writing this paper. So we would like to have, in fact, with multiple myeloma, the same concept that we have in CML. This is one of my patients, I treated him with Glivec a long time ago in 2002. He did reach MRD negativity during a very long period of time, 7 years. I did stop Glivec, and you see that 10 years later, the patient did not relapse with a sustained MRD negativity. But multiple myeloma is not CML. That's a very heterogeneous disease. We don't have a single mutation. So this very simple picture that we are all of us knowing very well, maybe not true, in fact, for multiple myeloma. We have to keep in mind that it took us 15 years to demonstrate that it was possible to stop Glivec, and we know that now that when patients are remaining during 5 years MRD negative with Glivec for CML, we can stop Glivec. Half of them will never relapse and half of them will relapse, but we can retreat them with Glivec and it will be effective subsequently. One of the first attempts to look at sustained MRD negativity is coming from the Italian group into the Forte study reported by Francesca Gai from Torino. In fact, they looked at KRD with or without stem cell transplantation into the study. And they were able to demonstrate that the MRD negativity rates were very high when patients were treated with KRD alone, 12 cycles, or KRD plus stem cell transplantation. You see the VGPR rate, almost 90% before maintenance, and the MRD negativity rates in blue seems to be identical, in fact, 45% with KRD alone, 58% with KRD plus stem cell transplantation. So very similar results at 10 to the minus 5. But they looked subsequently 1 year later at MRD negativity. And what is the outcome, in fact, of the patients? You see here patients treated with KRD autologous stem cell transplantation in green and KRD alone in blue. And 1 year apart, you see that there is a difference when looking at MRD negativity confirmed after 1 year. We have a higher rate of MRD persistent negativity, 90% in the stem cell transplantation arm versus 72% in the KRD arm alone, in fact. Suggesting that, okay, you can reach 10 to the minus 5, but this threshold will be maintained more easily in the stem cell transplantation arm versus KRD alone. So this is an important information. Definitely we need long follow-up. That was for the first time the assessment of MRD negativity sustained at 1 year. This is also true, in fact, in the relapse setting. And you know that into CASTOR, into POLLUX, we also looked at sustained MRD negativity. I showed you this picture previously, PFS and overall survival based on MRD negativity with DRD or Lendex or with DVD or VD. So we need to reach MRD negativity. That's really clear. And this is the outcome of patients for overall survival. And when we are looking at sustained MRD negativity, those patients that were able to stay MRD negative 6 months apart, their outcome is really improved in the 2 trials. And this is also true when that's overall survival. It was previously PFS. And this is also true at 12 months when you are looking at a progression-free survival at 12 months. Patients sustain MRD negative. Those patients are never progressing with the DRD. Very few, in fact, patients, no patients are have sustained MRD negativity into CASTOR with VD alone, but some of them can remain MRD negative more than 1 year with DARA VD. You see the outcome is very important, very clear for PFS. And this is also true for overall survival. You don't have any death in the DARA VD arm of CASTOR and only 1 death, in fact, for patients MRD negative during more than 1 year into the POLLUX study. So this concept is becoming very important. And for example, into this Spanish study that we discussed previously with VRD, autologous stem cell transplantation, VRD consolidation, patients subsequently are randomized to receive either LEN maintenance or LEN plus ixazomib with a serial assessment, an annual assessment of MRD negativity. And we will see if this concept is very important for the final outcome of the patients. So we are now awaiting for those results of this very important maintenance study from the Spanish group. We are doing the same, in fact, for VRD and daratumumab into the Perseus study. The study did enroll almost 700 patients, and we are also looking during maintenance either with lenalidomide or len plus daratumumab at this concept of sustained MRD negativity over time during a long period of time of maintenance. At ASH last year, we have heard about this very provocative study, phase 2 study, the MASTER study from Dr. Costa and one US cooperative group. They looked at KRD daratumumab, so a very effective quadruplet in the setting of stem cell transplantation. And patients were treated with 4 cycles of induction with the quadruplet, KRD DARA, stem cell transplantation, consolidation with KRD DARA times 4, and another consolidation phase with 4 additional cycles of KRD DARA. And you see here this yellow star, MRD, was systematically assessed after each step of the strategy, after induction, after autologous stem cell transplantation, after the first consolidation phase, after the second consolidation phase. So a serial assessment with NGS 10 to the minus 5. And when patients were twice consecutively MRD negative, the treatment was stopped. And interestingly, they showed that after induction, 40% of the patients were able to reach MRD negativity. And after stem cell transplantation, 73% of the patients were MRD negative. And the treatment was stopped for those patients MRD negative after induction and after stem cell transplantation. And interestingly, after 4 additional cycles of consolidation, 82% of the patients were MRD negative. It means that more than 70% of the patients, for more than 70% of the patients, the treatment was stopped after induction and stem cell transplantation because they were MRD negative. And Dr. Costa mentioned that no patient MRD negative did relapse, in fact, after a short follow-up. So that's a very provocative study. The first study showing that you may change the treatment or you may decide to stop the treatment when patients were MRD negative during a long period of time. This is the future French study that we are going to start very soon in the next month. We are going to use for young patients eligible for stem cell transplantation, we are going to use a quadruplet induction with KRD isatuximab, so the second monoclonal antibody targeting CD38. And after 6 cycles, we are going to assess MRD by NGS. And if patients are MRD negative at the top of the slides, so good risk patients, because induction, MRD negative 10 to the minus 5, so a very deep response, patients will be randomized to stem cell transplantation versus no stem cell transplantation. And the primary endpoint of the study is MRD negativity before maintenance. So we would like, in fact, to demonstrate that we need or we don't need stem cell transplantation anymore in patients reaching MRD negativity after induction. So to my opinion, that's a very important study to demonstrate that in the context of MRD negativity, we can maybe get rid of high-dose melphalan and stem cell transplantation. So to conclude, and this is my last slide, I think that I showed you that MRD negativity is a very important prognostic factor, both for PFS and OS. The optimal threshold probably is not 10 to the minus 5, but 10 to the minus 6. I think that PET-CT and flow are complementary. We don't have yet data on the PET and NGS within the same study. And I think that the concept of sustained MRD negativity is very important. And I thank you for your very kind attention today.